you see this slide?
Yes, we can see it.
Today I will talk about cases with difficult resection and reconstruction. In 2022, I performed 520 cases of surgery, including 276 malignant tumor and 244 benign tumor. Most cases were 167. Actually, I count this number from 2011. From 2011, total surgery cases were 4,361, and most cases most cases were 565. And my other major is nail surgery. It was 158 cases. Based on my such cases, I will introduce my cases with scalp major lesion, the triangle area.
Involved. And also with some additional report that perineural invasion is seen in the section 2, and also some basal squamous component in the section 3. So things is difficult to orient all the perineural invasion and then also the basal squamous part. I referred him to the radiation therapy. So what I have learned from this patient is any suspicious persistent or refractory lesions whereas dermoscopy evaluation to rule out the malignancy. If in doubt, we will suggest patient to have biopsy. And familiar with the dermoscopy findings of the infiltrating basal cell helps the dermatology surgeon to make the pre-OP plan more precisely and to decrease the Mohs stages. Some invasive pathology characteristics like perineural invasion may not be noted during the frozen sections. And finally, we should consider to delay reconstruction if the complete clearance of the tumor is not confirmed yet. Now we're trying to perform some ex vivo OCT because some area like in Africa, their specimens were very poorly prepared. So maybe ex vivo OCT will be better for them. But in our hospital, since our frozen section can be ready in 30 minutes, we still perform the ordinary frozen section for the most micrographic surgery. Okay, so I mix all the good time with our mentors and Professor Park and Professor Oh. Thank you.
To share my experience, if you have that kind of very thin epithelial wound after secondary intention healing, you can de-epithelialize all the fragile areas and just put the punch grafts on it. And it heals into a very, very robust skin graft. So it can really improve the quality of the patient's lives. Thank you.
Great idea.
Can I ask one question for Dr. Oh? And I think you and your patient so patient, very, very impressive. And I wonder whether you said you always use PD to suture the galea. You use PDS.
Yes, right.
Do you usually do that?
Yes.
Okay. In my experience, actually, in scalp surgery, I don't use any subdermal suture or other suture, except skin sutures, because skin suture is only one area scalp is because a skin suture is needed, because if you usually when we do suture for the scalp, we always pull through a layer of a full layer with the suture through the scalp, especially Kee suture. So if several suture is tightened to make the suture lines, and next step is quite easy to suture, and scalp flap itself can compress the underlying tissues, so no other compression dressing or other compression procedure will usually not be needed in scalp area. So for a long time, in my experience, there also one good advantage of the not use of the subdermal or gallia suture is there's no very little chance of temporary alopecia or alopecia. So my experience, it is so good. But if you do gallia sutures and you have a more experience, introduce the lizard later.